Hello, friends. Happy New Year to all of you. Today, I'm starting a new lecture series called Lecture Series 2025. I hope you all will have a great year ahead and you will all get whatever you wanted. Today, I'm going to talk on a very important Viva topic, that is the instruments. And maybe in another couple of days, I will be talking about the same, that is Viva specimens and instruments. Today's instrument I'm going to talk is a very important one, day-to-day instrument, that is vacuum. The question always asked is whether vacuum to be used or whether forceps to be used. Which is the right choice? Of course, this is a common question that crosses everyone's mind. What is happening is we are slowly losing the art of instrumental delivery, especially that of forceps. In fact, forceps has seen many changes. I'm going to talk in detail about that tomorrow. But today, I'm going to talk on vacuum, which is more commonly used. Vacuum or forceps? Historically, obstetric forceps was the primary instrument used, as I said. Recently, this has been superseded by vacuum in many countries. Talking about my own college, Kasturba Hospital, Manipal, you can see that this is the old stats, but still relevant. Forceps was almost 2% and vacuum is double that, 4.45%. How to make the right choice? Is operator's choice the right choice? Probably yes. If you are used to one particular type of instrument, then you will definitely do better with that instrument. Local practice. Yes, most of the places now vacuum is the local practice. So you see from your seniors and continue to use the same one. But if you are working in a place where forceps is the practice, then you will pick up that. Maternal and fetal well-being. Of course, you will soon realize in which are the situations vacuum is the most appropriate choice, or rather vacuum is contraindicated, and where forceps is better than vacuum, considering maternal and fetal well-being. Occasionally, consumer preference. Sometimes now the patients are well informed through Google Doctor or WhatsApp University, and they will themselves ask for a particular instrument, or they will say, please don't use this particular instrument. So it is consumer preference. Finally, it is clinical scenario, and I've highlighted that we should be guided by clinical scenario rather than any of the others. What are the indications for vacuum in general? Maternal indications, exhaustion. So mother is exhausted, she cannot push anymore. So you will have to help her. You will use a vacuum for that. Failure to progress in second stage. Now, what happens in second stage? We know that there are two phases, pelvic phase and perineal phase. There is internal rotation, which is the most important thing that happens in the second stage. And that takes a lot of time, especially in the posterior positions. And if there is a failure of progress, then you may have to use an instrument, and better instrument is vacuum. You will soon realize why. To shorten the second stage in medical disorders, yes, we always teach whenever we talk about the delivery in, let's say, anemia complicating pregnancy, heart disease complicating pregnancy, preeclampsia, and all such disorders, it is better to shorten the second stage where we use instrument as a prophylaxis. And there, of course, vacuum is also indicated. What about fetal indication? Fetal distress in second stage, where you want to quickly deliver the baby, we may use vacuum. People argue that forceps is better, but then if the criteria to use forceps, especially the station of the head or the rotation of the head, is not complete, then we may use vacuum. That leads me to the most important. Just now you saw rotation. Yes. Whenever the rotation of the head is required, vacuum is definitely preferred nowadays compared to kill and forceps, which was used in the past for rotation. Yes, there are some teachers who now want to bring back kill and forceps, but then it is not cup of everyone's tea. Killing forceps has got its own drawbacks. You have to first apply in one direction, rotate, remove, reapply. It has got its own complications and problems. Instead of that, the better instrument is vacuum, which will do both the jobs. What are the two jobs of any instrument that we expect? Number one is rotation. Number two is traction. So vacuum does both of them, especially the rotation, especially when it is not complete. If the head is slightly higher, also you can use vacuum instead of using mid-cavity forceps. So in fact, nowadays, we have not only given up Killian forceps, which was a rotation forceps, we have also given up mid-cavity forceps. Only outlet forceps is used in the modern obstetrics, whereas vacuum can do all the job. Of course, we don't use vacuum at the mid-cavity level. We always prefer a lower level, at least +2 station, where, of course, a low forceps can also do the job, but vacuum does a better job because at that station, some amount of rotation is still remaining. So vacuum, as you pull down, it will cause auto rotation of the head. So vacuum is preferred both for rotation as well as for traction of the head. Special indications for vacuum are fetal distress towards the end of first stage. Now, second stage, it is no doubt in that, but end of first stage, at the beginning of second stage, when probably the head is slightly higher, and if there's a fetal distress, you feel that it is too late to take her for cesarean section, and it is probably too early for forceps, where vacuum is definitely can be used. But again, I want to tell you, even in modern obstetrics, vacuum is preferred at a lower stations rather than at the mid cavity. Cord prolapse after full dilatation. Yes, there you have to hasten the delivery, quickly have to deliver the baby. Again, you feel that taking the patient to the OT will take some time, or using anesthesia and other things will take some time, by which time the baby may die. So you want to quickly finish the delivery in the labor room itself, and the best instrument for that is vacuum. Second of the twins. Again, I have put it in the bracket mature baby because you will see in the subsequent slide, premature baby is a contraindication for vacuum, soft head, or when the skull bones are not mature, it is better not to use vacuum. So that's why I've written, if the babies are mature, it is at term, and if you want to quickly deliver the second baby, because we know that if the gap is more than half an hour between the two babies, then the second baby is at lot of compromise or danger. That's why to hasten the delivery of the second of the twins, you can use vacuum. Vacuum at cesarean section. Yes, suppose you have a difficulty in delivering the head, then vacuum is used, same as the forceps in case of cesarean section. We always keep a vacuum with a long tubing ready in Manipal. And if there's a difficulty in delivering the head, we may use vacuum. Especially this can happen if there is a floating head, you can use vacuum better. What are the prerequisites for vacuum? We always know about the prerequisites of forceps, and there's an acronym called forceps itself. But it is almost similar for vacuum, and the prerequisites are the maternal ones, full dilatation of cervix. Yes, there are different types of cups in vacuum, where they say that a smaller cup can be used at even 8 centimeter dilatation or 9 centimeter dilatation. But again, I want to tell you, it is always preferred to use vacuum at full dilatation, because at 8 centimeter dilatation, yes, you can use vacuum. Some amount of head can be always there to apply the vacuum cup. But what happens is when you forcibly deliver, there can be very bad cervical tears and cervical lacerations, and so also the vaginal lacerations. That's why it's always preferred to wait for full dilatation of cervix. That doesn't mean that you have to always wait for full dilatation of cervix. Full dilatation is preferred. Cooperation of the patient is very, very, very important. That's the main difference between vacuum and forceps. In forceps, you can use 100% of the effort from the obstetrician side. So that is the advantage of forceps. It is like forcibly you deliver. You can remember that way. Whereas vacuum, you definitely need uterine contractions as well as patient's cooperation. Some sort of secondary powers are required. Of course, in the previous slide, you saw that if the mother is exhausted, you can use vacuum, but it is preferable to have some amount of cooperation, some amount of secondary powers from the patient also. Good uterine contraction, just now I told you, one of the requisites for vacuum is good uterine contraction, whereas it is not the case in case of forceps. As far as fetus is concerned, full engagement of the head, no need of full rotation. Full rotation is a must for forceps, that to outlet forceps. Whereas for vacuum, we don't need full rotation, but full engagement. Of course, it goes without saying that unless the head is engaged, and we don't even use any instrument, head should be engaged, and it is preferable. I've been telling last few minutes that it is better that the head is at +2 station or +3 station rather than just at 0 station when the head is engaged. So I want to highlight good uterine contractions once again. What are the basic rules with vacuum delivery? Application to delivery time should not be more than 15 minutes. That means you may have one slip or maximum 2 slips, not more than that. Suppose I start the vacuum. Nowadays, we have very fast vacuums. It can be created within a minute. And thereafter, within another 10 to 12 minutes, you must deliver the baby. This is a basic rule of vacuum. If it is not, then you know that it's very difficult. Better to take a first section rather than using another instrument. Head, not just scalp, should descend with each pull. See what happens, sometimes there will be a lot of caput, and in fact, a big caput is a contraindication for vacuum delivery, but sometimes with little small caput you will try to use, and when you pull, you feel that the head is coming down, but actually the head is not coming down, just the caput is coming down. So head, not just the scalp, should descend with each pull. Not more than 2 reapplications of the cup. That's what I just now told you. It may slip first time, you can reapply, maybe one more time, but thereafter you should suspect that there's something wrong, maybe malrotation or maybe something wrong in your application. So the slipping more than 2 times is not allowed. No forceps after vacuum. This is called sequential use of instruments. No forceps after vacuum. I want to tell this again loudly and clearly. Same way, no vacuum after failure of forceps. So don't choose 2 instruments for the same delivery. If you fail with forceps, better to go for section. If you fail with vacuum, better to go for section, not sequential use of instruments. Again, I'm telling this, the use of sequential instrument is associated with an increased risk of trauma to the infant, hence not recommended. This is just to reiterate the same factor. I'm dedicating one more slide. No. Contraindications for vacuum. I just already mentioned one. I will talk about more now. Maternal cervix not fully dilated. Again, I have explained this earlier. Let me repeat one more time. Yes, you can apply vacuum at 8 or 9 centimeters. The small cup is meant for that, but it is always preferable to use vacuum when cervix is fully dilated. That's why I put it under contraindication. Uncooperative mother, the same thing what I said earlier, prerequisite, now I'm putting it as contraindication. If the mother is non-cooperative, better not use this. Cup disengaged more than 2 times. So again, what I mentioned earlier, I'm putting it in a different way. If there is disengagement of 2 times, it is a contraindication to continue. Failed forceps. Yes, I have already told you sequential instruments are not allowed. If the forceps has failed, take a first section, not for vacuum. Same way, if vacuum fails, take a first section, not for forceps. What are the other one? Fetal contraindications, unengaged head. Of course, this goes without saying. This is silly, actually. I should not be putting this here. But many textbooks mention, that's why I put it here, unengaged head, thinking that, vacuum can deliver a high head. But how high is the question? In fact, I'm telling again and again, it is better to have at least +2 station. Excessive caput or molding. A small amount of caput is all right. Small molding, which is still disengageable molding, is all right. But a severe molding, pathological molding, where there is overlap and it cannot be separated, or is a large caput, that means the head has been there for a long time. The actual head, the bony head, is higher up. So in these cases, vacuum is contraindicated. Face presentation or aftercoming head. Even in aftercoming head of the breech, the face is the one which is presenting. In both of them, vacuum is contraindicated because you don't want to disfigure the face, isn't it? So vacuum is contraindicated there. Preterm baby, I told you earlier also. In the second of the twins, I said if it is mature baby only, you have to use vacuum. Preterm baby, because the scalp is very soft and the bones are not very mature, so you should not use vacuum. And the gap between the sutures are also wide. Bleeding from the fetal scalp. If there's a bleeding, you should not be using this. First, I'll just call you back, sir. Bleeding from the fetal scalp. Osteogenesis imperfecta. Again, the problem is with the bones. That's why we should not be using vacuum. So in these situations, it is better to go for the forceps. Whenever there's excessive caput or molding or face presentation or aftercoming of the head, whether you can use Piper's forceps. Preterm baby, in fact, it is advised to deliver preterm baby in a protected cage of the forceps, where you can prevent intraventricular hemorrhage. Bleeding from the scalp, again, vacuum is not the one which will increase the bleeding, so forceps is better. So also in osteogenesis imperfecta. There is something called a flexion point. This is usually asked in the exams, which is nothing but the point where you apply the vacuum. As you can see here, it is the anterior fontanelle, 3 centimeters posterior to the posterior border of the anterior fontanelle. So from here, posterior border of the anterior fontanelle, it should be at least having a 3 centimeters to the rim of the cup. So it will exactly posterior. Now, why is this? This is because when you apply the vacuum as posterior as possible, you will maintain the flexion. Always the trick of the delivery is maintain the flexion of the head so that the shortest suboccipitobregmatic diameter, which is 9.5 centimeter, comes into play. So that's why this point is very, very important. This question is definitely asked in the exam. So as you can see here, the distance from the posterior border of the anterior fontanelle to the rim of the cup is 3 centimeters, at least 2 fingers breadth. That is the best. So it will cause flexion of the head. Factors to be considered. One is station and position of the presenting part. I already told many, many times about this. Station is definitely better, is to have +2 and +3. Position, of course, not a posterior position, maybe at least just short of full rotation is an ideal case for vacuum. Caput and molding of the fetal head to be assessed properly. A large caput and severe molding should be avoided. Comfort, morale, and cooperation of the mother is very important. Experience of the operator. Of course, nowadays, most of us are experienced with vacuum. Availability of necessary equipment. There should be there in the labor room. Now I come to the minor points in the vacuum. There are different types of vacuum cups and vacuums, so we should know how to use them. They are classified according to the softness of the vacuum cup, where if it is rigid, they are metallic. And again, in metallic, you have 3 different sizes. As I told you, the smallest one is used for 8 centimeters. Next one is 9. Other one is 10. Always prefer the 10 because there is full dilatation. The soft cups, elastic or silicone cup, these are used for straightforward deliveries. These have, if you're not well versed with the metallic cup application, this is an easy instrument to be used. Depending upon the requirement of rotation, the anterior cup, as you can see here, the knob or the tubing is on the top of the cup and central or eccentric. Whereas posterior cup, as you can see, it is on the side of the cup, so that it will easily go to the posterior part without damaging the rectum. If the connection was on top of the tube, it will damage the rectum. How do you choose? As I said already, the soft cup is mostly for a well-flexed head, so that you don't have to flex it with the metallic cup. Anterior position, obviously, and average size baby, and where the caput is absent. And it goes without saying if there's a low cavity head. Whereas the metallic cup is for deflexed head and posterior position, above average size of the baby, and caput is present, and low to mid is the station of the head. So this is the difference. As you can see, well flexed, deflexed, anterior, posterior, average, above average, caput, absent, here it is present, low cavity, low to mid cavity. This is the difference. So anterior cup, as I said, obvious when there is occipital anterior position. Posterior cup when there is occipital posterior position. In anterior cup, the tubing is on top of the cup, whereas here it's on the side of the cup. So it won't damage the rectum, which is here. Stumbling blocks. Improper initial assessment. This is very, very important, whether it is vacuum application or forceps application. You have to properly assess. Number one is that you see whether there is caput, whether there is in molding, how much is the rotation by palpating for the sagittal switches. It should be less than 45 degrees, and whether the station is +2 or +3. So unless you do this, you should not apply any instrument. And the most important, as far as the vacuum is concerned, you should see all around whether there's enough space for auto rotation of the head. Sometimes if the head is jammed there, if there's no scope for the rotation, no instrument is going to help. So you should make sure that there's enough space around the head for auto rotation of the head. So head should be, as I mentioned many, many times, it should not be very high. It should be at least +2 station. Uncertain position, I told you already, it should be at least, less than 45 degrees, if not completely rotated. Leaking equipment. So equipment should be thoroughly checked, whether the tubings or the cup, all these things. Incorrect cup. As I said, you should not use elastic cup for a difficult delivery. Probably the metallic cup is better here. And also, this is a posterior position, so you have to use the cup with a side knob. Cup anterior or lateral, this picture shows this is not the right position. None of these are right position. This is the right position. Whereas you can see there is a 3 centimeter gap between the posterior border of the anterior fontanelle. Oblique traction. So the traction is very important. This question is asked in the exam. How do you do the traction? Whether you pull downwards, forwards, upwards. In forceps, we say that. But in vacuum, you have to remember only one thing. The traction is always perpendicular to the cup. So automatically, initially it will be down, then it is horizontal, then it is upwards. But you don't say that. You always say the traction is perpendicular to the surface of the cup. I hope it's very clear. See, initially it is down, then horizontal, then upwards. This goes automatically. But you are not going to say that. You are going to say it's always perpendicular to the cup. Then we have excessive caput or molding. That can be a stumbling block. And poor maternal assistance. See, I'm telling the same thing again and again in different ways in different slides. The main points are almost the same. What are the complications of vacuum? Of course, vacuum is the safest one we say, but there are still some complications in vacuum. One is laceration to the vagina. Suppose you don't apply properly. If you apply a little bit on the vagina without checking, you have to always go all around. You have to pass your finger all around to make sure that the vacuum cup is applied only on the scalp of the baby and not any part of the cervix or even vagina or vulva, for example. And then if you apply vacuum after this, wrong application, and there will be obvious lacerations. Minor scalp trauma can still occur on the baby. Cephalhematomas and subperineuritic hemorrhage is known, but this is nothing to worry. This will resolve on its own. Intracranial hemorrhage is very, very rare, especially if you use it for a little bit preterm baby by mistake. It can happen. And retinal hemorrhage, we had one such case, but thank God it will resolve on its own within 3 to 6 months. There won't be any problems. Now, having discussed all these things, let's see what is the Cochrane review on vacuum deliveries, vacuum versus forceps. Vacuum extractor associated with significantly less maternal trauma. Whenever it is less, I put green. Maternal trauma is very less with vacuum. Another review says more vaginal deliveries, fewer cesarean sections with vacuum extraction. Yes, most of us are now going towards vacuum delivery. Vacuum extraction is associated with a lower usage of regional and general anesthesia. So whatever simple anesthesia, epidural anesthesia is not required, you can simply use the local anesthesia as used for episiotomy. Is episiotomy required for vacuum delivery? Depends. If it is priming, mostly yes. Especially at the time of delivery, you may have to give some episiotomy. Otherwise, there will be very bad perineal tears or lacerations. A clean-cut wound is always better. But with apparently less pain at delivery and significantly less pain at 24 hours. Vacuum extractor was associated with an increase in neonatal cephalometoma and retinal hemorrhages, but as I said, neither of these problems have been linked to long-term complications. They resolve on their own. No significant difference in numbers of babies requiring phototherapy, which is especially because of cephalometoma. Cephalometoma, we know there can be jaundice because of hemolysis, but no significant difference in number of babies requiring that due to vacuum. Coming to soft and rigid cups, the soft cups seem to be appropriate for straightforward deliveries, which I have told already, whereas other review says soft cups less harmful in terms of causing scalp lacerations and hence vertical transmission of HIV. In fact, it should not be used in HIV patients or whenever there is some bleeding. As far as rapid versus slow negative pressure, nowadays, most of the vacuum that we use are rapid vacuums. Rapid negative pressure reduces the duration of procedure, obviously, especially if there is a distress, we go for rapid negative pressure. Whilst there is no evidence of differences in maternal and neonatal outcomes, whether you use rapid or slow negative pressures. What are the advantages of vacuum? Just to wrap up whatever I said so far, it's more effective than forceps in some situations, such as deflexed occipito-posterior position, where a long rotation is required. It's a simpler technique to learn and is less dependent on accurate assessment of the fetal head position. Suppose you have a doubt about the position, especially due to a small caput, vacuum is better than forceps. There are some concerns though. Vacuum extractor is more likely to fail than forceps is a question. Errors. This failure is due to errors in technique, especially incorrect cup application or pulling in a wrong direction. Other one is it's not possible to pull as hard with the instrument. In forceps, when you use it, you can use sometimes even brute force, whereas that's not possible with vacuum. It will slip to use, especially if the vacuum was not created properly and if there was a caput or if there was any molding. To wind up the talk, take-home message. There's an increasing trend towards vacuum. Soft cups are for more straightforward deliveries. Vacuum is the best choice when rotational delivery is anticipated. Rigid cup is better for relatively higher stations and greater rotation, especially for head with caput and molding. Anterior cup for anterior and posterior cup for posterior position. Rapid negative pressure reduces duration of delivery without adverse outcome. Choice is determined by the clinical scenario, availability of equipment, expertise. Vacuum extractor rather than forceps appears to reduce maternal morbidity. The reduction in cephalometoma and retinal hemorrhages seen with forceps may be a compensatory benefit. Neither of these problems have been linked to long-term complications. Finally, no forceps after vacuum, no vacuum after forceps. In other words, sequential instrument is not acceptable. Now that you know, go ahead and use this vacuum as they used in Three Idiots. I'm joking. And thank you so much. Let's meet again with another instrument, forceps, tomorrow.